Good morning. Welcome to this morning's session. It is titled Theranostics, Pearls and Pitfalls. I'm Karen Fader, and this is Julie Croach, and we'll be chairing this session. The first guest we'd like to ask up is Dr. Jeff Chambray, and he's going to speak to us on what's new in thyroid therapy. Welcome.
So we'll talk a little bit about thyroid cancer therapy and what's sort of changing a little bit. Oh, okay. So once upon a time when we used to look at patients, we had a very simplistic approach. So if you had breast cancer, you got a mastectomy, and that was pretty much it. But things have changed, and now when we look at a patient, we try not just to come up with one approach, but we have many different approaches that we can use to deal with their cancer. And the actual name of the game now is not what treatment you give, but making sure you select the appropriate one for your patient. So there's a lot of things that actually are happening. I know that we all tend to think that thyroid cancer hasn't really changed over the years, but in fact, there's a lot of new things happening. There are new drugs coming out. Genomics is making a big difference as we characterise tumours better based on not just on how they look, but actually on the genes that drive them. And so what once upon a time was true, that tumours all seem the same and we could treat them the same way, we've now come to realise that that's completely not true, and what was perfectly appropriate for one subtype is completely inappropriate for a second. So we're going to have a targeted approach to the prevention, diagnosis and treatment of tumours based on each individual's specific characteristics. So I'm just going to try and cover a few things, which is looking at how we optimise therapy, how we minimise side effects, and what other new things might be coming up. So radioactive ion therapy has been around for a long time, even longer than me. The first treatment with radioiodine took place back in 1941, so during the Second World War. And pretty much for a long time, the standard of care was simply to give a fixed amount of isotope to everyone. Just for those with interest in history, so radio was a skin cream, contained radium. You may notice the doctor putting it out was a Dr. Curie, who has absolutely nothing to do with Madame Curie except the convenience of sharing the same name. So as we've gathered more knowledge about disease, we now know that not all thyroid cancers will benefit the same from radioactive iodine therapy, that there are lots of low-risk cancers, in fact, that need no therapy whatsoever. I'd say we need to look at how we're going to identify those who do and don't need treatment. There's been a lot of work over the years into categorising cancer, and that there are two main published sort of ways of doing that, which we'll get to. But in basic terms, we have histology. We just look at what the tumour looks like. We have the pathology. We are whereabouts are those cells being found? Are they in nodes or confined to thyroid? And then we now can look at the genetics and try and identify more aggressive genetic mutations. So the patient makes a difference. Are they young or old? Young do much better, and I'm very excited that young has now been reclassified as under 55. It used to be 45. So unfortunately, I'm still not young, but hopefully they'll bump it up next year and I'll get to be young again. Other health issues need to be taken into account. More and more, I think we need to ask our patients what do they want. In the past, again, we tended to stand up on a pedestal and just tell patients what they were going to get. Now we try and involve them a bit more. Their thyroglobulin level can give you a lot of information in how you should choose your treatment. And I just like to break it down really simply into two things. Am I treating residual cancer, or am I just cleaning up so I can do better surveillance for the patient? And if you sort of can break your patient up those two groups, it makes your life a bit more simplistic, which is a bit like me. So I'm just going to cover the TNM staging and the ATA guideline changes, and a few other things that I think might be helpful. So the new ATA guidelines came out in 2015. While some areas remain a bit controversial, I think it's fair to say that most of us have embraced the guidelines. They are rather lengthy and complicated, but they do give you good and relatively clear guidelines of what to do with patient who has X, Y, and Z. Also, the TNM guidelines have recently been upgraded for thyroid cancer, and they've made a few changes. The net effect, basically, of all the TNM changes has been to downstage thyroid cancer. So the general change is that what we used to think was aggressive, a lot of them we've backed off on, and we were backing off on the amount of treatment we're giving these patients because there's actually no evidence that they were getting any benefit from that radiation exposure. And so these changes in the TNM will change not just what we do, they should actually change extent of surgery. Some things now no longer need an entire thyroidectomy. You can just get away with a hemithyroidectomy, whether you need to give any iodine at all and how much you're going to give, and whether you need to give them post-therapy, suppressive therapy. So people have known for a long time that old patients do worse, but as I said, old has been reclassified. So if you're now under the age of 55, you're actually, the worst you can be is stage 2. So even if you have metastatic disease, you're still only a stage 2. Of course, it's a bit of an artificial construct that the minute you go from being aged 40 or 54, 11 months and 30 days, and you get one day older, all of a sudden your whole treatment paradigm changes. So I do think it's important when we look at this, we understand it's a continuum of risk. It's not a black and white cut-off of risk. There was a definition that we all used to pay a lot of attention to, which was extrathyroidal extension of tumour. So if the tumour grows out of the thyroid capsule, that was always thought to represent a worsening of your prognosis. However, minimal extension, where the tumour only goes into the surrounding fat, perithyroidal fat, for a long time I think we've all suspected that actually meant nothing, and that's been recognised now, and so that's been removed from the definition of T3. It's only if the tumour extends into skeletal muscle or other significant tissues that we consider it a significant finding. Nodal metastases also got a bit of a review. So in older patients, if you had any nodal metastases, you were stage 3. That's now been dropped down to stage 2. So looking at age, as I was alluding to, you can see that we have a, so there's my laser pointer here, that the survival with your tumour gets worse the older you get, and it's a pretty linear effect. There is no definite cut-off, and the 45, 55 age thing was a relatively arbitrary selection. So the American Thyroid Association guidelines also changed a number of things. There's been a lot of work looking at thyroid nodules. Now, I think everyone is pretty much aware that we all get thyroid nodules pretty much at some stage of our life, and that in the past there was a very black-white, if the thyroid nodule was more than 10 millimetres, it got a needle stuck in it. If you were younger and male, it didn't matter how big the nodule was, you'd end up with a needle being put into it. The ATA gave quite clear guidelines on subtypes of nodules that don't need biopsy, even if they're very big, because of their ultrasound appearance is so consistent with a benign subtype. And so hopefully that means we'll be doing a lot less biopsies, which is a good thing, because often you do biopsies and you get an atypical result, and that just means the patient goes down this spiralling course into more and more investigations. So in fact, I think the best thing you can do for many of your patients is to not let anyone biopsy a nodule that doesn't need it. So surgery, as I mentioned, for follicular adenomas and the NIFT-P subgroup, which has been recently defined, you can actually just take out half the thyroid because they're so low malignant potential, you don't need to worry about them. They're effectively a benign lesion. So that's for tumours under 4 centimetres in size and have no nodal involvement. That's actually acceptable treatment now. Preoperative ultrasound has been given a much bigger role than it used to have. It's actually quite strongly encouraged. If you've had someone with thyroid cancer, before you plan your surgery, do an ultrasound to look at all the nodes. If there's a suspicious node, you biopsy that node, and then clearly if that node's positive, you're not going to be doing a hemithyroidectomy. So you're getting information on how to manage the patient well up front. So ultrasound got a big tick. The concept of low risk of recurrence was expanded. Again, a whole bigger range of tumours has been put into this low risk group. For example, micrometastases in the lymph node, so less than 2 millimetre deposits of tumour, up to 5 of those are now still considered low risk. And for the first time, genetics did get a mention. BRAF and TERT mutations, which we'll discuss, actually got put into their criteria for assessing seriousness of disease. And they finally defined this concept of radioactive iodine-resistant tumours. So radioiodine, unfortunately, is not a completely benign therapy. It's pretty good, but it does have risks. There's no doubt, I think, that we all believe there's benefit to treating patients who have intermediate to high-risk disease. But the higher the dose we give them, the higher the risk that they'll get side effects. So we need to balance those two pressures on us. And we really just want to try and get the dose just right. So one of the first things looking at differential dosing was a high-low study. So this was one of two trials that both came out in the same year. Now, one was British and one was French, and that almost kicked off the next World War. But they managed to come to an agreement and, in fact, had quite similar findings in the end. What they looked at was giving 1 gig versus 4 gig for ablation. So this is in the patients who, in my interpretation, they're the ones we're cleaning up. Like, these are not your patients who you think have got aggressive cancer. And they looked at ablation rates, and they found that the low dose was just as effective for ablation as the high dose. And it comes with a few benefits. You don't need to keep the patient in hospital for as long. If you give them a 1 gig dose, our patients go home the next day. So they just have an overnight stay. And of course, they get less side effects. So some thyroid cancers we know are just cured by surgery. And you don't need to give any other treatment. These are the small, low-risk ones. The unifocal ones with no nodes, clinically no nodes with those micrometastases. If you have multifocal disease, but each site of multifocal disease is less than 1 centimetre, there's got to be no tumour invasion of other tissues, and the histology has to be in the non-aggressive group. One of the other features on histology that we do pay a lot of attention to is whether the tumour is invading the vascular spaces or you've got that extrathyroidal spread, because that's an indicator, we believe, of a more malignant process. It's a tumour more likely to spread if it's already starting to invade the vascular spaces. So in that entire group, you don't necessarily need to give routine iodine ablation. You can actually spare the patient that and just monitor them clinically. If you are going to give them something, then they should definitely be getting the 1 gigabecquerel dose. At our hospital, for some strange reason, a lot of the endocrinologists like to give 2 gigabecquerels. I think this is just, they found it too painful to go from 4 to 1. There's absolutely no science behind it, and I argue with them regularly, but they still write 2 gigabecquerels down. So sometimes I do it, sometimes I argue. So there's no evidence of any benefit in giving radioactive iodine to this particular group. So what about intermediate risk patients? So these are the patients who do have some perithyroidal extension, or they've got a clinically significant lymph node. That means the one you can feel. They've got the vascular invasion that we've discussed, and their histology is one of the more aggressive subtypes, such as tall cell or columnar, or a poorly differentiated tumour. So this is the first time the BRAF mutation got a mention. It's a tumour promoter gene, and it certainly is associated with a higher risk of recurrence. So these patients, we do offer radioactive iodine ablation. There is some limited evidence that there is improved survival in this group. Again, if you feel that there's only limited metastases, and for a while we felt that central compartment metastases were less important, T&M has now overruled that and said, no, you just treat all those nodes the same. So sometimes we give low dose, but most of these patients, we would give them a 4 gigabecquerel dose. What's the evidence that you get some improved survival? Well, there are these papers that have been published in the last few years. In the Rural paper, they had 21,000 intermediate risk patients, of which they gave radioactive therapy to just over 2/3. And they followed them up for 6 years, which is not the longest follow-up you would like for a thyroid cancer. But they showed a 29% reduction in the risk of death in that time group. And actually, interesting enough, showed a better reduction if you were young. So this paper sort of goes a bit against some of the other trends that people are putting out there. The Castagna paper also looked at intermediate risk, and they compared 1 versus 4 gig to see how they were doing with ablation and treatment. Again, they showed some improvement, not for the ablation rates. The ablation rate was the same. There was a slightly higher risk of recurrence, but the death rate was about the same. Now, at one meeting I went to, there's a guy called Van Nostrand in the US who's pretty highly regarded in thyroid. He actually said the reason why they didn't show a significant difference is actually you're not giving enough. He thinks we should be giving these patients 6 or 8 gig, and then you would actually demonstrate a benefit, but that work hasn't been done. Okay, what's high-risk disease? So people with macroscopic tumour, people whose tumour hasn't been completely resected, so they actually have known left tumour behind. People who've got distant metastatic disease, so bony disease or lung disease. If after your surgery your thyroglobulin stays high, sort of above 10, that's actually an independent risk factor. So it's something that's easy to measure, and you can see that this patient is at higher risk of recurrence because their thyroglobulin is high post-surgery. If you've got big nodes and if you've got extensive vascular invasion. So again, there's probably benefit of radioiodine in these patients. Again, if you look at the patients who achieve what's called resolution of iodine-avid disease, so after their ablation you can no longer find iodine-avid disease, they have a much better survival than those in whom we cannot get rid of all their iodine-avid disease. And these patients, you're going to give somewhere between 4 and 6 gigabecquerels. So at North Shore, we treat about 150 patients a year, and that number is pretty stable. In 2011, 25% of our patients got a low dose, and now that's up to about 38%. I think that's still, you'd think that maybe should be higher, but I think that's because we're not treating patients who in the past would have got low dose. So in fact, we probably, as a group, are giving a much less amount of radioactive iodine to the low-risk patients. And the high dose has reduced in counterpoint to that. So what do we know about the genetics? So the BRAF V600E and the TERT mutations both increase cell growth. So they're both important genetic abnormalities for tumours. The BRAF mutation is the most common mutation you'll find in papillary thyroid cancer. And in fact, 45% of all papillary thyroid cancers will have this mutation. It's associated with bigger tumours, more extrathyroidal extension, more nodal disease, and therefore higher risk of recurrence. If you look at the this page out of the ATA guidelines, and I love this page. I have this printed out and stuck up next to me for when I'm doing the thyroid patients. They go from low risk to high risk, and you can see that the BRAF mutation now starts to figure as something that pushes the patient's risks up. I highly recommend this page to you. Okay. If you look at some of the studies of the effect of BRAF and TERT mutations on patient survival, the key message here is that while either is a little bit bad, both together is much, much worse. And so the combination of the two mutations work in tandem to promote the malignancy of the tumour. Okay, if you have non-radioactive, non-radioiodine tumours, then life gets a bit more difficult. So we no longer have a good global therapy in radioactive iodine. And this is the definition that's currently out there. So it's no radioactive iodine uptake in malignant tissues. It's radioactive uptake in some, but not all, or it's a metastatic disease that progresses despite adequate radioactive iodine therapy. So even if you're giving what you think is good doses and they progress, then that now means that they're radioiodine refractory. And they often have what we call the flip-flop effect, so that as they go iodine negative, they become FDG positive. In this group, when radioactive iodine is no longer available, we now have tyrosine kinase inhibitors. So these are a cytotoxic chemotherapy drug that we can use. Cytotoxic chemotherapy drugs have been shown to not do as well as the TKIs, and they're a promising therapy. They target multiple sites, but mainly the VEGF receptor. And lenvatinib is now approved in Australia for therapy of thyroid cancer patients. There's been a number of trials looking at the response rate, but certainly lenvatinib's had the best results. If you look at the survival in older patients who are put on these TKI inhibitors, so the blue line's a patient who got the drug and they did much better than those who did not. So who are you going to give your TKI drugs to? Look, rapidly progressive disease is something that we say needs it. How do you define rapidly progressive disease is a bit of a discussion point, but things that are rapidly growing in size, or where there's a lot of tumour, or where the patient has significant symptoms, but often it's just in the patient who you've got nothing else to offer. So that's the changes in what we can do, is the things that we can change to reduce the side effects. So salivary glands problems are the most common side effect of our radioactive iodine therapy. And up to half the patients that we give radioactive iodine to will have some problem. That's dose dependent. But they get acute pain, they get dry mouth, altered taste. And the really concerning thing is that 16% of patients still have symptoms at 5 years. So while a lot of people have transient, the rest do not. So this was a study where they were just looking at uptake with TECI, and they graded the uptake, and they showed that a lot of patients had permanent change to their salivary function. So why do we get that? Well, 24% of the dose is excreted by your salivary glands, and it's mediated by exactly the same sodium iodide importer that we use otherwise. I'm just going to move along a little bit, because what I really want to talk about are these agents, the lemon juice, the sour candies, and how we should do that. We all used to tell everyone to suck on these lollies, and the thought was that we'll just force that iodine out and that would be a good thing. However, then there was the paper from Nakata, and he showed that if you actually gave the lollies in the first 24 hours, you made things worse. By stimulating the gland, you actually were getting more side effects, not less. And that was a bit of an unexpected finding, and it was felt that maybe by stimulating the gland, you're actually increasing blood flow and you're increasing the overall delivery of iodine to that gland. So in the end, it gets more of a dose than you had before. So in Jensen in 2010, 2014, he's done a lot of work on this. They did I-124 dosimetry. They broke patients up into a control group. One they just gave Tazoscarb and one they gave lemon to. And they scanned them and they looked at the vascularity. And they showed that there was no doubt that the lemon group had increased vascularity, as shown on the colour flow Doppler. So that was sort of supporting that theory. And they did dosimetry, and they were able to document, in fact, that you did get a higher dose when you gave patients lemon juice. So I'm just going to move on past that to say what is a little bit different is there's been some arguments lately that if you gave it more frequently, maybe that's better. So Silverstein in the US is very keen on this, and he makes his patients have lollies every half hour to hour. He wakes them up all night to give it. But unfortunately, the one study that he did do, he did with dexamethasone in it. And so even though he showed they did much better, I think in the end we don't know if they did much better because he'd given them dexamethasone pre-treatment, or whether it was because of the aggressive salivary stimulation that he used. I have 2 minutes left. Okay. Amifostine is another drug that was trialled. So this was a drug that is meant to be a radioprotector for normal tissues. It scavenges free radicals. So it doesn't just protect the thyroid cancer. And in fact, the studies have shown that, in fact, there's very little effect of it on the cancer cells. So that's good. It's protecting the other cells. But there's been mixed results from the studies. And the 2 early studies showed improved outcomes, but the more recent studies with more patients have shown no benefit from amifostine. I think it's fallen out of review. And the Cochrane review of this suggested there was no benefit whatsoever. The other thing to note is that the move to lower dose and the move to recombinant TSH has meant that we're getting much less of these symptoms. So one of the great things about recombinant TSH is you wash out the excess iodine much quicker than we used to, so the total body dosimetry's gone down. And so now salivary symptoms have dropped to 5.4% when they were much higher in the withdrawal population. And I think I'll probably just stop there because I think I'm running out of time. So I think we're going to have questions at the end. Thank you.
Thank you. Oh.
Thank you, Jeff. I'd like to welcome our next speaker, who is Professor Michael Hoffman from the Peter MacCallum Cancer Centre here in Melbourne.
Thank you. It's a pleasure to talk about some of the work we've been doing in PSMA theranostics. I think this sort of work is going to spread, so some of you may not be doing therapy quite yet, but with lutetium. But I think in a few years' time, this is going to be pretty much standard of care, at least around Australia, but probably really globally. So the target is PSMA, prostate-specific membrane antigen. This is a cell surface glycoprotein that's really overexpressed in prostate cancer. And we can target these with small molecules that bind with high affinity to these receptors. So these aren't antibodies, they're small molecules, and there's a variety of imaging ones, either labelled with gallium or fluorine, and we can switch from a positron emitter to a beta emitter for therapy. The normal distribution looks a little bit like the radioactive iodine scans that Jeff was showing us in the previous talk. It's got some ideal properties for therapy. It's got pretty low background. There is high kidney uptake. You obviously don't get that with iodine, so it's renally excreted. The pioneering work for this came out of Heidelberg in Germany, and they showed back in 2015 this single case report, which was pretty compelling. A patient with metastatic disease both in bones and lymph nodes, where after 2 cycles of this therapy, there was complete resolution of these abnormalities. This is our theranostic program at Peter Mac, and you can see there's been a lot of growth over the last decade. The red colour is lutetium dotatate for treating neuroendocrine tumours, and the NET program's grown enormously over the decade. But you can see in the last 3 years, our prostate theranostics has commenced. A few ones back in 2014 and growing. And I suspect in a few years' time, the prostate bars will be much larger than the neuroendocrine bars. But you can note the number of therapies per year. Last year, we did 500 cycles of therapy and continues to grow, a marker of demand. So we presented our results of our prospective study that we did in Peter Mac in our centre at a European Oncology meeting last year. This was a prospective study looking at the efficacy and safety in 30 men with really advanced metastatic prostate cancer. So theranostics, for those who aren't aware, is a sort of combination. The word thera is from therapeutic and gnostics from diagnostics. So we have a targeted therapeutic, here lutetium PSMA 617, and a diagnostic companion, which for this study was PSMA 11. These are very similar molecules. They're actually slightly different. The 617 is optimised for therapy, so it's got slightly more rapid renal excretion, so lower kidney uptake and slightly higher tumour uptake. It's nice that we can image what we're treating, so we can select patients that are suitable for therapy on the basis of a PSMA PET. And we can also do post-therapy imaging with lutetium. Much like iodine, it emits some beta that we can image. So in this study, we took men with castration-resistant disease that had really progressed after docetaxel and enzalutamide and abiraterone, which are the standard therapies available. And these patients had not many treatment options left. So they were end of the line. Many of these patients would have been referred on to palliative care physicians with no treatment options left. They had to have high uptake on a PSMA PET. And we also did FDG on all these patients, which is something we adapted from our neuroendocrine experience, that the combination of both a targeted sort of tumour-specific agent like dotatate or PSMA in combination with FDG can be useful. So we don't treat everyone. This is a patient we didn't treat, PSMA PET, showing very widespread bone disease and also liver disease, but very low intensity uptake. SUVs are sort of 5 and 6, which is not intense enough to treat. So in our study, we needed uptake more than 1.5 times the intensity of normal liver activity, which we don't see here. Another patient, this patient's got lots of bony disease that we can see is lighting up very brightly on the PSMA PET, but there's a big mass in the mediastinum here, a big lymph node, and it's got no PSMA uptake, but it's lighting up very brightly on the FDG PET. So this is kind of a dominant site of disease that we know we can't target with this therapy, and that's bad because it's also the most aggressive, most quickly growing site of disease. So if we see dominant sites of what we call discordant FDG disease, they're not eligible for treatment. So is this patient suitable for therapy? They've got a high-risk prostate cancer, or they've advanced metastatic disease, they've failed all conventional therapies, and you can see the SUV max is extremely high, of 55, very widespread bone disease. Who thinks this patient's suitable for therapy? Yes, okay. All right, you weren't listening to the last 2 slides. We need the FDG. So the FDG shows a surprise. There's actually a lot of liver disease, which is very FDG avid and widespread throughout the liver, which really has almost no PSMA uptake. So despite appearing to be suitable on the PSMA PET, this patient's got a liver packed of tumour, which we couldn't target, and the patient, if we were to treat them, I'm sure would die quite rapidly from progressive liver disease. So this is the sort of patient we would not treat, despite the PSMA PET initially looking very favourable. So since we did this trial prospectively, we got some very high quality data on toxicity. The main toxicity is dry mouth, and we actually saw that in the majority of patients. But this was usually pretty minor. In fact, I think we overstated it because Because it was prospective, patients came back for multiple visits. We asked them, do you have dry mouth? They said yes. We said, is it bothering you? They said no, but it's recorded as a grade 1 salivary toxicity. And it's probably a significant minority of these patients where it was really problematic, and there was certainly no grade 3 or 4 salivary toxicities. We did see reduction in blood counts, thrombocytopenia, in a significant proportion of patients, but these were possibly, probably or definitely related. A lot of these patients had had a lot of chemotherapy before. In fact, almost all the patients that got hematotoxicity had abnormal bloods to begin with, a marker of effects of prior chemotherapy and poor low marrow reserve or very extensive marrow disease. And we saw dry eyes because we do get lacrimal gland uptake in a few patients as well. Importantly, we had no episodes of febrile neutropenia, something you would see with chemotherapy. If the platelets did decline, they recovered within about a month or started rising. And we didn't do any measures to try to minimise xerostomia. Jeff showed us some in the previous talk. We couldn't find any that were particularly effective, so there were no lozenges or anything else done. This was the primary endpoint, which was PSA response, and we saw a greater than 50% reduction in PSA, which is an oncological endpoint, which is considered an excellent response in almost 60% of patients. So this was quite impressive data for a group of patients that were end of the line. And almost, in fact, every patient except for one had a degree of PSA decline. And I think this is a marker of our patient selection, incorporating that FDG to make sure we can target all the sites of disease. Here's a group of patients that did particularly well. All these 6 patients had 96% or greater reduction in their PSA, and we'll look at their images on the next slide. They all had really quite what we now term an exceptional response. You can see the PSA numbers here from 15 to undetectable with a complete response on PSMA PET. I think all these top patients actually had a complete response on PSMA PET imaging with virtual reduction in PSA to 0, and these patients had pretty good responses but not complete. Here's an example of a patient who was end of the line, no other treatment options, had chemotherapy, even second-line chemotherapy, has this retroperitoneal lymph node that was enlarging quite rapidly, had a lot of back pain because of that, very PSMA avid, also very FDG avid, but concordant, very rapidly rising PSA. We treated them, we did some dosimetry. From the first dose, we were able to get 175 gray into this lymph node. So it's no surprise that this patient was going to have a pretty spectacular response, which is exactly what we saw. I think this patient got 3 cycles of therapy. PSA went down to almost undetectable. PSA response was complete, at least on PET scanning, and you can see this lymph node shrinking to a sub-centimetre node. So by anatomic criteria, a complete response as well. And what was more impressive was the durability of this response, out to 450 days without any other therapies. So we did look at anatomic responses, and they were quite marked. This is soft tissue that we can measure, and we saw complete responses in 30% and partial responses in roughly 50%. This overstates the benefit a bit because we can't see the bone lesions on the CT, and they're invariably the ones that do not respond as well and that do progress with this therapy. We looked at survival, and if you achieved a PSA response over 50%, patients were living around 17 months, and if you didn't get a great PSA response, 10 months. So this tells us that this is not a curative therapy. Most of these patients were dying in a relatively short period of time, albeit at the end of the line at the time they came to us. So how did the patients die? Most of them progressed with diffuse marrow disease over time, and in fact 13 out of our 22 deaths were marrow replacement with a leukoerythroblastic picture on the blood film and PSMA PET scans that ended up looking something like this. So although we're not curing patients, we are probably extending their life, but more importantly, improving their quality of life. So in patients with pain, we saw after a single dose improvement in 37%. This is not a little bit of improvement, but it's a greater than 10-point improvement on this standardized scoring system, which is quite a marked reduction in pain. And patients often tell us that their pain gets better within hours of having the therapy. Sometimes 24 hours later, they can be pain-free. It is a therapy that we can continue to use, a bit like radioactive iodine. If it works and you progress, we can treat again. So this is a patient with very advanced disease. We do post-therapy imaging, and we can see after the second cycle there was not much uptake. This was a marker of good response, with the PSA dropping from 1,000 down to sort of below 100 after a single cycle. And then we did a PSMA PET, which showed a complete response. So we weren't going to continue to give more and more lutetium PSMA to this patient at this time point, because the target's not there and the toxicity will start to become high. So we wait for the patient to progress, which happened about 10 months later. And then as the PSA rose, we gave a third cycle, saw a nice response, fourth cycle, fifth cycle, and eventually the extent of disease was just too great and the patient's blood counts too low to further treat this patient. But if you look at the total duration of response from here all the way out to when the patient died over here, it's a long period of time. It's almost 800 days. And if you look at how long they responded to the therapies that came before, the duration of responses was much shorter. So as a last line of therapy, now this is pretty compelling data that this is a treatment with very high activity. We do dosimetry, particularly as part of these early phase study. We do 3 time point quantitative SPECT CT. So this is a SPECT CT from sort of head to almost knees. We do it at 4 hours, 24 hours, 96 hours. This is quantitative, so every voxel is in megabecquerels per mil. A lot of the commercial vendors, you can now do this out of the box. This is done on a Siemens Intivo camera. We can combine all these images to develop a voxel-based dosimetry map. And we have some automated in-house software to do this. And it essentially looks at the area under the curve in each voxel. And from that, we can generate a single image like this, where every pixel is in grey. So anything in red received 50 grey or over, and anything in the grey colour scale got less than 15 grey. And these are really neat images to show our referrers how the therapy is working. We can see these bilateral adrenal metastases receiving almost 70 grey, and the bone metastases 33 grey, and normal organs, really low doses, parotid glands 4 greys and under, kidneys 3 grey. These are the doses in the entire cohort of 30 patients. Normal organs compared to tumour uptake, we're sort of getting 10 times more tumour uptake than what we see in parotid glands or kidneys. And if you get higher dosimetry to tumours, we see higher response rates. So these are patients that had an over 50% reduction in PSA and the doses to tumour versus those that had a less than 50%. And there's a clear difference between the two. Those interested in dosimetry more, I'm giving a dosimetry talk later this afternoon. I think it may be in the 2:30 session, so that'll be a little bit more detail. So we've adapted that phase 2 trial, and there's now a randomised Australia-wide trial on. It's called the TheraP trial, standing for Theranostic PSMA, and it's a randomised trial of lutetium PSMA compared to cabazitaxel chemotherapy. It's a 1-to-1 randomisation in a 200-patient study. We have 4 sites activated in Australia at the moment, and this study will open at 10 sites around Australia. A little bit of the lutetium administration protocol. It's actually pretty straightforward. We encourage oral hydration to sort of maximise renal excretion, but we actually don't use any intravenous hydration. We did get some nausea and vomiting we found in our phase 2 study. So now we pre-medicate with dexamethasone and granisetron or a similar agent as we do in our neuroendocrine tumours. We make sure the IV is adequately patent, because the last thing you want to do is tissue a dose of lutetium, so we need to be really careful about that. We check their blood pressure and other vital signs. We infuse it over 2 to 5 minutes. We encourage them to keep drinking and to void. And by Australian regulations, when they're less than 9 microsieverts per hour at 2 metres, they're allowed to go home, and that's typically 2 to 4 hours later. And then they get some dexamethasone and granisetron for 2 days. Radiation precautions for patients. This will differ depending which jurisdiction you're in, but for the therapy study, these are our recommendations, and they're pretty standard. I won't go through them in any detail. We did a trip to ANSTO, where our lutetium is made for this study. This is the core of the nuclear reactor with the ANSTO team and some of the TheraP trial team, and it's great to have an Australian source of lutetium to use in these studies to benefit our patients. So thank you very much. There's a great effort from our nuclear medicine team at Peter Mac. questions at the end. Is that the plan?
Yes, we can do questions at the end. Thank you, Michael. Our next speaker is Liz Bailey. She will be discussing peptide receptor radionuclide therapy using lutetium daughter SSR. And Liz also is from Royal North Shore.
Thanks, Julie. So I'm going to be talking specifically about peptide receptor radionuclide therapy as opposed to lutetium PSMA that you've just heard about. The treatment regimes are quite similar but different, would be what I would say. You're dealing with very different types of diseases and different side effect profiles. So the treatments are similar but slightly different. So I suppose I'd just start off by saying that, in fact, we've been doing theranostics for quite a while. Jeff Shembry, you heard him talk about iodine. Iodine is basically a form of theranostics. We often do diagnostic procedures on these patients to identify sites of disease and then treat them. Many years ago, when I first started, when I was 3 years old, because I'm only 25, we were actually doing routinely diagnostic procedures to identify disease and then targeting the treatment with things like radioactive iodine. These days we're tending to use some blood markers for that instead of that. And we've used iodine for a really, really long time. We've used it to treat thyroid cancer. We tag it with MIBG to treat pheochromocytomas, neuroblastomas. We've tagged it with Lopidol in the past to treat liver cancers. We've also now target Y90 to use it for liver-directed therapy by giving people SIRS. And we've traditionally used it to treat rheumatoid arthritis by tagging it to yttrium Y90 citrate. And of course, there's lots of new alpha therapies. I know there was a great session on actinium earlier in the week, but radium-223 is being used to treat bone cancers. However, the reason that lutetium is so attractive is because it isn't just a therapeutic, but as Michael has shown, it's a great imaging agent. We can do fantastic dosimetry. We can personalise treatment. We can actually look at the tumour uptake. We can actually identify sites of disease. We can decide the best treatment to give these patients to have the most effective course of treatment. And the lutetium properties for imaging are very desirable, as they are the therapeutic components. So the tissue penetration is 2 millimetres. It's reactor produced, so in fact, as you saw, you can get it locally within Australia, and internationally you can get it through the German reactors. It has a short beta range. It emits an energy, a gamma energy that's actually very amenable to imaging on a traditional gamma camera. You can do 2D and 3D imaging on these patients. And the labelling process is not overly complicated, but it has a long physical half-life, which means that the therapy will be effective. So lutetium has really been at the forefront of the change in theranostics, certainly within Australia, for a very, very long time. And the Peter Mac was certainly at the forefront of this for a very long time. So what specifically is peptide receptor radionuclide therapy? Well, it is a treatment modality that's used to treat tumours that have express somatostatin receptors. And these somatostatin receptors tend to be expressed in neuroendocrine tumours. So these are of the carcinoid variety, but they also include things like paragangliomas. We've also treated pheochromocytomas and neuroblastomas. And these tumours express a high density of these somatostatin receptors, not just on abnormal tissues, but also on normal tissues. So the principles are the same as for lutetium PSMA uptake, in that you will have a receptor in the body. In this particular instance, it's a somatostatin receptor. You're able to have a ligand that can actually target that receptor within the body. In this instance, it's actually the octreotate or the DOTA SSR receptor. You can tag that via a linker, which in this instance is the DOTA linker with a radioactive material. In this instance, it's either gallium-68 for the diagnostics and lutetium-177 for the therapeutics. And then it will attach itself to wherever you express somatostatin receptors within the body. Now, there is a high density of these lesions of these receptors within normal tissue, so in the brain, the peripheral nervous system, the pancreas, the gastrointestinal tract, as well as renally excreted. So by binding it with lutetium, you're able to have a therapeutic effect. So I still classify it as a relatively new treatment because I'm not sure we're 100% sure on the best way to give it. Obviously, there are conversations around giving amino acids for renoprotection. Do you need it? Do you not need it? Do you need to give radiosensitizers? Are they more effective, or do they just cause more side effects? How many cycles should you give? How often should you give the cycles? Do you just need to do 2 cycles and then monitor the patient, then only give them more cycles when they recur? So I classify that as a new treatment because we really don't know exactly what to do in some of these patients, and it's still being heavily researched. So lutetium dotatate shows an improved, if you use lutetium dotatate, it shows an improved binding of these somatostatin receptor tissues compared to other tags that are out there. So in Australia, we use dotatate because it's the one that's actually readily available. We're quite lucky in Australia. There were certainly periods of time overseas where this product was not available. There are other options like DOTA-TOC and DOTA-NOC. However, the big advantage of TATE is that it has a higher affinity on somatostatin receptors, specifically somatostatin receptor subtype 2, and that has a 9-fold increase in uptake. So as you can see from this image, the one on the left-hand side here is actually your dotatate. One on the right-hand side is DOTA-TOC. You can see uptake in the lesion for both of them. However, the avidity is significantly higher than it is for the DOTA-TOC, which means that you're actually going to have a more effective therapeutic effect. So predominantly people are going with using dotatate if it's available. So when should you do it? Well, it's a bit like lutetium PSMA. You need to have uptake on a gallium-68 scan if you have it. If you don't have uptake on a gallium-68 scan, then you don't actually have evidence that there are somatostatin receptors, therefore you shouldn't be treating the patient. And you need to understand the course of the disease, so the grade of the disease, and you can use other markers to help you with that. So there's something called a Ki-67, and it's a marker of proliferation. So in lower grade tumours, which are associated with high somatostatin receptor expressing tumours, they have a low proliferative index. So an index of less than 5 is usually a grade 1, less than 20 is a grade 2 to 3. These are the tumours that tend to be more amenable to having lutetium-based therapies than those that are higher grades. So as the grade increases, as the tumour becomes more aggressive, the tumour uptake will change from being DOTA-avid to FDG-avid in a similar process to PSMA. So how do we select our patients? Well, your patients obviously need to have disease progression. So this is still not first-line therapy, and I think it's a long way off being first-line therapy. These patients need to have failed some type of therapy. Usually, traditionally, there's somatostatin analogues, which they use to control their disease, but also to control their symptoms. And they also need to have dotatate avidity. They need to have low uptake on an FDG scan. By that, we mean that it has to be less than the dotatate or equivalent. So here's just an example of what I mean by that. So on the left-hand side, you've got a case of a patient that has FDG negative study and a dotatate positive study. On the right-hand side, you've got the opposite. So do you think I should treat the patient on the left or the patient on the right? Left-hand side? And would anyone treat the patient on the left with lutetium dotatate? Anyone treat the patient on the right with lutetium dotatate? Or no one to treat the patient? Nah, let's not treat the patient. We don't treat anyone. But based on what we understand of the tumour biology, these are the ideal patients, okay? So they don't have any high-grade disease. Remember, if they've got FDG-avid disease but no dotatate evidence of disease, in fact, when you give the lutetium, all you're going to do is knock out normal tissue, okay? So you've got salivary glands, you've got kidneys, and you're actually not going to have any effect on the tumour at all. If, however, you have FDG negative and you've got dotatate receptors, then these are the ideal patients to proceed to therapy. Now, nuclear medicine tend to be the controllers of these types of treatments, so it is appropriate that we consult these patients and have an understanding of their eligibility and suitability for the treatment, because we are actually administering the treatment. As you can see from the previous scan, there is significant renal uptake. So you do need to do kidney assessments. In Australia, we tend to use DTPA GFR assessments of kidney as well as creatinines and eGFRs. In Europe, they tend to use MAG3 as well as potentially eGFRs and creatinines. So whatever your practice is within your organisation, but we tend to use DTPA GFRs. You need to understand the health status of the patient. So if you've got a patient who's got significant liver complications or haematologic complications, then you most probably should not treat these patients. And because you're dealing with a carcinoid type disease as opposed to prostate cancer, carcinoid can actually cause heart disease, it can cause mitral valve disease. So all of our patients need to have a cardiac assessment prior to being deemed eligible for treatment. And you're also giving them a large fluid load when they're in the department, because you're giving them 1 to 2 litres of amino acids. So you need to make sure that they're able to have that fluid load. Excuse me. We need to make sure that we know the tumour pathology, and again that relates to the KI. So making sure that they're actually a grade 1 or grade 2 tumour. If they're a more aggressive tumour, then the treatment is likely to be less effective. And we also make sure that we have other imaging tests. So it is important that you're still doing CTs. These patients are often being monitored with CTs, so using the RECIST criteria. So you do need to make sure that they've had those procedures as well. And you need to have an understanding of any prior treatments that may cause complications down the track, especially if they've had a lot of extensive chemotherapy or external beam therapy that may affect their haematologic status. There are obvious contraindications for this treatment. Pregnancy and breastfeeding is a standard contraindication for most nuclear medicine therapeutics. They need to have a reasonable life expectancy. You don't want somebody to unfortunately pass away 2 weeks after you give them the treatment. They need to have a relatively good performance status, again for compliance, and it's kind of the same as these psychiatric illnesses. It's for compliance. You're giving somebody radioactive treatment. They need to be able to comply with the requirements of the treatment. They need to be able to take the medications you need them to give, and they need to be able to be aware of the radiation precautions they need to follow after they've been sent home. And again, but all of the other stuff we've already mentioned, renal function, liver function, cardiac function, all need to be assessed. And if they fall outside this criteria, then they're really not eligible for this treatment. There are side effects. The side effects are different than you get with lutetium PSMA. A lot of patients do get nausea. They can also get headaches and vomiting. A lot of the patients, however, are being pre-treated with radiosensitizers, so they're giving 5-FU or capecitabine. So there's a little bit of controversy as to whether some of the nausea and things are actually caused by the chemotherapy. The amino acids themselves can actually cause some of these side effects. So it's not really clear-cut as to whether the side effects are specifically caused by the lutetium dotatate or whether they're caused by some other complication. The way that we reduce side effects in these patients is and that includes carcinoid side effects, is by actually using a variable infusion rate. So we inject the patients at a slower infusion rate initially to assess any potential side effects, and if they're okay, we would infuse it at a faster rate. The infusion takes about 20 to 25 minutes to administer to the patients. And we can also monitor for carcinoid type syndromes as well. So you've got to be very aware that these patients have carcinoid disease, and the standard carcinoid side effects like flushing, you need to keep an eye on that. You need to have the reversal drugs within your department so that if somebody does go into a full-blown carcinoid, you have the ability to manage that side effect. There are a few long-term side effects. The renal toxicity is relatively minor. People naturally have a reduction in their GFR as part of just getting old. Unfortunately, as you get older, everything starts to fall apart, including your kidneys, but very slowly. But it can result in a minor reduction in kidney function over a long period of time. Some patients can get bone marrow toxicity. These tend to be patients that have really large tumour burden to start with. Most patients that have less disease don't have as many side effects. And we also recommend our patients, female patients, avoid pregnancy for 6 months, and that if young males are coming, we recommend that they go and do any appropriate sperm donations prior to any treatment. And in a similar way to what Michael was talking about for lutetium PSMA, we also calculate kidney dosimetry. We, at the moment, are using 2 methods. So we're doing the physicists are doing a comparative study of using 2D whole body sweeps to calculate kidney dosimetry, as well as SPECT-CT. We will be transitioning completely over to SPECT-CT hopefully in the next couple of months. But we calculate tumour dose per cycle to get a total tumour radiation dose to the kidneys for the complete 4 cycles of the treatment. The toxicity to kidneys is based on external beam radiotherapy, and though they suggest that a dose of less than 23 gray is okay. It's not going to affect your kidneys. However, the treatment we're giving is slightly different, but we have, on average, anywhere from 10 to 15 gray given to the kidneys, and that shouldn't create any issues. The procedure itself, we do use radiosensitizers for our lutetium-based therapies. However, that is variable. We use the decision as to whether they should or they shouldn't have chemotherapy often in the hands of the medical oncologists. If a patient is having a drop in platelets, we don't give them chemotherapy as a radiosensitizer. If the patient will have compliance issues, we also don't give it. But if they can, we would give them capecitabine. They start it 1 week before and they take it for 2 weeks after the treatment. We also make sure that we check all their bloods before they come in to make sure that they haven't had significant drops in platelets, they haven't had changes in their white cell counts, or any changes in their kidney function that may preclude them from being suitable for the treatment. The important thing to remember with this also is that you're dealing with somatostatin receptors, so you need to look at what other treatments they're on. A majority of these carcinoid-type patients are on short and long-acting somatostatin analogues. These drugs are used routinely in this type of disease for symptom control as well as disease progression control. So these need to be stopped prior to treatment. We like to stop the long-actings 4 weeks prior. And if they're quite symptomatic, they can be transferred over to short-acting SSAs as long as they stop those 12 to 24 hours before treatment. Now, there's evidence coming out to suggest that maybe this isn't needed. At the moment, we still do it, but it can cause significant problems for patients because they can become acutely symptomatic, including chronic diarrhoea, if they come off these medications. So if they become significantly with chronic diarrhoea, it will send all their blood results off, and it will send potentially their kidney function off as well, which may preclude them from having the treatment. And there's evidence coming out that, in fact, if they take these medications, it actually has no impact on the somatostatin binding of the lutetium within the body. So some of these things, again, new therapies, this may change, but at the moment that's the current protocol. I think that's followed in most places. Most patients get given 4 cycles at 8 to 12-week intervals. It's done on an outpatient basis unless we believe the patient may be at high risk of having a hypertensive crisis or having a carcinoid crisis. They tend to be the patients that have the pulmonary carcinoids. They are at higher risk of having complications after the treatment. So patients are within the department for about 4 to 6 hours. We pre-med them with ondansetron and dexamethasone in a similar way as they do for lutetium PSMA. The ondansetron is to prevent their nausea. The patients are always also requested to take it for 2 days after they go home, also to prevent any side effects for the 48 to 72 hours after the treatment. Because of the kidney toxicity, we actually do give the patients an infusion of amino acids. It started 30 minutes before the infusion of lutetium, continued for 2 to 4 hours after the administration of the lutetium, and that time is varied based on the patient's baseline kidney function. We, like the Peter Mac, are trying to do dosimetry in all of these patients, so we're actually scanning patients at 30 minutes after injection, as well as at multiple time points. When you do 5 patients in a day, that's a lot of imaging. But we scan the patients at blood pool, so 30 minutes after injection. We scan them at 4 hours, 24 hours, and 96 to 120 hours after injection, so that we can accurately calculate kidney dosimetry at the moment, but ultimately to accurately calculate tumour dosimetry. We are hopeful that at some point this full imaging regime will just be done at cycle 1. We will then be able to predict the dosimetry and the washout from kidneys, and then at subsequent cycles only do limited imaging. It's quite intensive for the patients as well. Some of these patients are in a lot of pain, so it can be quite labour intensive for them to comply with these requirements. Obviously, you need to do all the safety precautions, checking their blood pressures, their pulses. If you're dealing with an insulinoma, so insulinomas are also treated with lutetium dotatate, you need to make sure you're checking their blood sugar level during the procedure. So this is the imaging regime. So this is the patient's dotatate scan, the scan at 30 minutes, 4 hours, 24 hours and 96 hours. And as you can see, the blood pool clearance washes out and you've got good retention in the tumours itself. So just a couple of case studies to finish off. So this is a 36-year-old female with a pancreatic neuroendocrine tumour that was diagnosed back in 2011. She was T3N1 staging. She had a KI67 of 1%, so that's a grade 1 tumour. She has been treated with those somatostatin analogues for a long period of time. She's been given TACE, which is a liver-directed therapy that's administered under radiology, where they put the chemotherapy directly into the liver. She had been given lutetium at a another site prior to coming and visiting us. She'd also had some more liver-directed therapy. However, her disease had progressed significantly and she was not particularly well. So when she came to see us, she had this uptake, which is very, very nasty. So she had a lot of liver disease. She had a lot of disease in her chest and in her abdomen. We gave her multiple doses of lutetium, and as you can see, she's had a fantastic response. So the disease in the chest is gone, the disease in the liver has reduced, and more importantly than anything, her symptoms reduced significantly, which often is the case. It's a little bit different to lutetium PSMA in that sometimes you don't actually see a great response on your gallium dotatate imaging. However, the quality of life improvements for the patient are often the most significant thing, including the significant reduction in the nasty side effects of the disease. The most important one of those is the flushing and the chronic diarrhoea. Some of these patients can have diarrhoea up to 30 times a day. And this is just an example that I actually got out of the literature, and I somehow should have the Peter MacCallum at the bottom here. This is actually published by the Peter MacCallum, showing beautiful response over the various cycles. So they've got nasty disease, and by the end of their cycles, they've had significant improvement of uptake. That's a rarity. We don't often get the opportunity to present cases like that. And just one last case. The reason I present this gentleman's case is that he was actually our very first lutate that we ever did at my campus many, many years ago. He was a lovely 44-year-old gentleman who had a very nasty disease. He had had a whole bunch of treatments. He'd been on these SSRs for a long period of time. He'd had previous radiotherapy because he has nasty bone disease. And he came to us really quite unwell. In fact, he had to be an inpatient of the hospital for his treatment, and I think you'll see why he was most probably unwell. So he's the perfect candidate for lutetium dotatate. He had no uptake or very little uptake on his FDG scan, but he had extraordinary uptake on his dotatate. So all of these are bone lesions, and he had terrible disease in his liver. And he was very, very unwell at the time of the treatment. So we went ahead and we gave him therapy. So these are his 4 cycles of treatment. I think the thing to note from all of this is that he's actually had if you actually looked at the CTs, he's had a reduction in the volume of his liver. So his liver kind of shrunk. The disease has shrunk down significantly in his liver. Some of the lesions in his bones have decreased in avidity. But the most important thing for this lovely 44-year-old man who had 2 small children is that he was basically bedridden at this cycle. By cycle 4, he was playing soccer with his children in the backyard, and he took great delight in painting his house because he'd actually, after cycle 2, dropped his pain medications by 50%. By cycle 3, he no longer took pain medication. So even though you're not visually seeing a significant change, the quality of life is often one of the best measures of the effectiveness of the treatment for dotatate. And this man did have some follow-up imaging. So this is one of his dotatate scans that was done after a few cycles of lutetium, and you can actually see that there has been a reduction in the avidity of some of these liver lesions, mild reduction in some of the bone lesions, but it's not significant. But by this point in time, this man was no longer on pain medications. So lutetium is really an ideal tracer for radioisotope treatment in nuclear medicine. It has a relatively mild toxicity compared to some of the fairly aggressive chemotherapies and other treatments that are out there. The radiation exposure to staff and to members of the public and the safety profile in regards to radiation is very good. It can be imaged so that you can identify the uptake of the tumours, but so that you can do tumour dosimetry so you can start to personalise the treatment for these patients. And I think certainly it's already happening in some facilities, but we'll be moving towards personalising the therapy based on the initial uptake of disease on their cycle 1, and then adjusting the amount of lutetium that you should be giving in subsequent cycles based on the tumour burden and the uptake profile that's identified at their initial cycling. Thank you for your time.
Thank you, Liz. I'd like to invite the panel members the speakers to invite us up here so they can take some questions, please. If anyone's got any questions, could you please use the mic that's in the centre of the room? And yep.
I'm Yuji Kuge from Hokkaido University, Japan. I'd like to ask to Professor Hoffman. My question is about gallium-68 PSMA compound. You show the images, and in your phase 2 study, you only use gallium-68 PSMA 11, only 11, not for 617, right?
So the imaging is with gallium labelled to PSMA 11, and the therapy is lutetium labelled to PSMA 617. But we could have imaged with gallium 617 as well. They're really extremely similar. It's just that I think all the imaging protocols have evolved using gallium PSMA 11, and part of that's just around logistics. PSMA 11 has no patent.
Okay.
So it's freely available, whereas the 617 does have a patent.
Okay. Thank you very much.
Are there any further questions? I have a question for Jeff. With the introduction of genetic testing, do you think that's going to have a big impact on how in the future management of thyroid cancer?
So I think the genetics are still being explored, and a lot of research is underway. I think it's more to do with the selection of the types of therapy that we'll use in the patients who are no longer available to receive radioactive iodine therapy. Clearly, if you're going to use a TKI, you want to pick someone who's got the appropriate mutation that will respond to that. How much further that will go in thyroid cancer, I'm not sure if there'll be any new stunning developments on the genetic line.
I have a question for Liz. Liz, you mentioned several times throughout your talk sort of the impact to the amount of imaging that had to be done, the technologists, their practice, the impact to the department. Could you just expand on that a little bit? Actually, how much of an impact there is in moving to this theranostics?
Well, it depends on how much fancy imaging you want to do and how you want to use your imaging. If you're wanting to use your imaging to be able to better optimise the treatment for patients, to be able to calculate dosimetry to kidneys and dosimetry to tumours, then unfortunately you don't really have many choices but to do a fairly comprehensive imaging protocol. If we treat 5 lutetium patients in one day, which is actually our fairly standard protocol, we actually have to lock out a gamma camera for that whole entire day, and usually for about 60% of the following day, as well as the same amount of time the following week. So it can have dramatic impacts on your workflow and the way that you design your workflow for those days that you're actually offering a theranostics service. For us, it's going to dramatically change because we're just about to start lutetium PSMA, and we're actually just about to start copper in meningiomas, so copper sartate in meningiomas, which will require similar imaging regime. So I think departments that are going to offer a lot of theranostics will end up having to have a camera that will be dedicated purely to doing all of the imaging on these patients. The other thing, of course, to remember is for your staff is that radiation exposure needs to be monitored closely, but the exposure that you get from lutetium is actually less than you think it is. Our physicists have done some measurements on the exposure to the stuff, and it's not significantly more than you would potentially get from standing next to a patient having a cystectomy or a cardiac procedure. So it's actually not too bad, but you do have to be very cognizant of that and make sure that you follow good practices.
I believe we have a question from the floor.
Just a question for Michael. Liz, I like your point that, lutate is not really a first-line therapy. With the amazing results you guys are getting with the lutetium PSMA, Michael, do you think it's going to sort of get to a point where it's going to be used earlier? Do you think that's going to have a place earlier in the treatment cycle of these? It's purely speculation. It's not a question necessarily.
Yeah, it's good to speculate. Look, I think for thyroid cancer, it's first-line therapy, and there's no reason both PRRT and PSMA-directed therapies may be first-line in the future. I think the efficacy we see is pretty compelling, and probably at Peter Mac we already do use PRRT first-line in highly selective cases, so patients that present with really more aggressive neuroendocrine tumours that we know won't respond to hormone therapy. We increasingly use PRRT first line, and our results are pretty good. I think that philosophy will spread, but we do need to do larger studies to really prove that in a more robust way if we want that to be standard of care and in guidelines.
Cool. Excellent. Thanks.
I'm going to ask Michael a question. With the PSMA therapies, what's your standard number of cycles that you offer the patients now, and what prompts your decision to terminate those number of cycles early?
So in the therapy study, which is really the study that you'll start shortly, we do up to 6 cycles separated by 6 to 8 weeks, and we do a dose de-escalation schedule. So we start first dose 8.5 gigabecquerel, and we take 0.5 gigabecquerel off for each cycle, which means if you get to cycle 6, you'll have 6 gigabecquerel. So you'll go from 8.5 down to 6, and every patient will have a SPECT CT at 24 hours, and that will determine whether you have another dose. If there's minimal PSMA uptake, then you'll stop. But importantly, you'll just pause. You'll remain on the trial, and at a time of PSA progression, you'll have another PSMA PET, and if your signal's still there, you'll just continue up to the maximum of 6 cycles. So that's our evolving schedule. We don't know the optimal schedule. This trial will help determine that. In our pilot study, we gave up to 4 cycles. And around 15 to 20% of patients did not get 4 cycles because they had an exceptional response, and they either had 2 or 3 cycles.
I have another question for Jeff. Could you give us an idea of the demographics of some of your patients, especially age? You talk about the young people versus the older people. Do you get many young people presenting with thyrocarcinoma?
So I always have to preface that that anecdotal evidence is not science. So I'll give you my anecdotal evidence. I think we seem to see a lot of young women in their sort of 20s and 30s, and they are often the group that will present with extensive nodal involvement at our presentation, and not infrequently they will have some degree of lung involvement as well. So they're the sort of the bad group we see in young patients that tend to be young women. Other than that, there's pretty much the full range of ages that you'll come across. The really nasty anaplastics tend to occur in the older patients. We don't see that too often, fortunately, in the younger group. So it affects all ages, but clearly some of those younger women have some nasty gene going on, and they tend to present early with bad disease. But almost all of those will be ultimately cured with radioactive iodine therapy. 75 to 90% of them will achieve complete remission.
Michael, can you explain why amino acid renoprotection is used in dotatate therapy but not in PSMA therapy?
Yeah, it's a very good question. It hasn't actually been as well studied as we should, but there was early work from Erasmus Medical Centre with dotatate that showed that amino acid infusions significantly decreased renal uptake, and they showed this in mice experiments and also in humans. And the methodology there is that octreotate is a larger peptide, and it's reabsorbed, so it's filtered into the kidneys, and then it's reabsorbed, so then it kind of circulates, and that creates a bit of a problem because you've got a lot of kidney exposure. And if you give lysine and arginine, which are smaller amino acids, the kidney will reabsorb those in preference, and therefore your dotatate gets excreted, so you protect the kidneys. It seems that the method of excretion with PSMA is completely different, so that phenomenon does not occur. The first groups in Germany that did PSMA actually just followed their NET protocols and gave amino acid infusions, but then people did some anecdotal experiments and it didn't seem to make any difference. And in our experience, the renal doses we get with PSMA are slightly less than neuroendocrine tumours without the amino acid protection. And we've also looked at, interestingly, patients with poor renal function. If you give patients with really low renal function dotatate, they get much higher levels of circulating radioactivity and much higher doses to kidney, whereas with PSMA it doesn't seem to matter. So I think PSMA is both filtered and secreted by the kidney and not reabsorbed, but there's not good evidence. That's just my impression.
And if I could just sort of add to that as well, the PSMA molecule, the most poorly named molecule in history because it's not very prostate specific, has direct binding sites on the renal tubular cells. So no matter what you give, you're going to get some direct binding to those renal tubules.
That's true. It's the most excellently named molecule, because if we called it glutamate carboxypeptidase therapy, I suspect no one would be interested in it.
That's a good point.
Are there any studies actually looking at measuring dose to kidneys with and without the renoprotection?
For prostate? For dotatate. I don't believe there are any in humans. There are small animal experiments from Erasmus showing that, but it has not been done in humans. It's major, it's several-fold, but some knowledgeable people have questioned the value of renoprotection with dotatate. So there is a lack of good quality science to support the practice, but I think everyone would be very nervous to change that. It's just so well established.
And Michael may recall better than me, but I think some of the initial work was done with Y90.
Yes.
And maybe there was a lot more renal damage from the Y90 than the lutetium. And so we're certainly coming to the belief that maybe the renal protection is not as necessary as was initially thought.
Yeah.
Hi, Michael. I've just got a question for you regarding the lutate PSMA and in a non-clinical trial setting, if you've got a patient with sort of a high burden of PSMA avid disease and a small amount of FDG avid, but they were likely to gain from treatment for sort of palliation and improved quality of life. In those cases, would you consider treating them even if they do have some FDG avid disease?
So if you were treating for bone pain, so a symptom, and you thought their symptoms would improve, that would seem pretty reasonable for palliative purposes. Yeah.
I did have one question around the FDG flip-flop. You may have said it, I may have missed it, but in terms of how many patients that occurs in, do you have any idea how often that happens?
So with PSMA in the population we treated, which is a pretty specific population, like post-chemo, post-abiraterone and enzalutamide, it was around 15%. But if you treat different cohorts, so if you use it earlier, it may be lower. We don't know.
Okay. All right. Thank you. Are there any other questions from the audience? All right. Hearing none, I'd like to thank our speakers. This was a very interesting, very informative session.